Now I request Dr. Devdasan to speak on the status of UHC in India, and I'm not going to introduce him because if you don't know him, then too bad. You shouldn't be here. Added by Girija.
Sujata Rao, and thank you all for this occasion. I'll try and keep it within the 10-minute limit. Yeah, everybody's been talking of universal health coverage since morning, and I think many of you all hopefully would have read the World Health Report and will be familiar with this cube within a cube, talking of population coverage, financial coverage, and services coverage. That is, we must achieve, if we want to achieve universal health coverage, 100% of the population should be covered with most of the services and with minimum out-of-pocket payment. But what in this debate is not coming clear is, where are we today in India in this path towards universal health coverage? Are we 20% on the path? Are we 50% on the path? Are we 75% on the path? That is something that I thought in the next 10 minutes, I will quickly go through. And yeah, if you look at the, again, WHO report 2010, they very clearly say, right in the beginning, that once you got a political buy-in, there's a vision of universal health coverage, the next step is on situational analysis. So that's what we are going to do. Now, usually, if you look at most literature on estimating where universal health coverage is, it is unidimensional. It's either they're talking of the population coverage or the financial coverage. For example, here, if you look at literature, they'll say what is the proportion of out-of-pocket payment in various countries. But this is only talking about financial coverage. This does not talk about who is paying that money and for what services. Now, if you talk of, again, this is from literature, you say, okay, what is the proportion of insured among countries in Southeast Asian countries? Okay, we know so many people are insured, so hopefully they are protected. But against what services? So always, our estimations, current estimations are always unidimensional or the maximum two-dimensional. Whereas when we're talking of universal health coverage, we need 3 dimensions. ILO has been trying to do this, and they have coined a word called access deficit method, very, very complex. For example, I'll give you this. They want to know what is the proportion that can access in government health services, private health services, etc., etc., etc. Now, for somebody like Sir Madan Gopal who's sitting here, he'll say, I don't have the time to calculate all this. I want something simple and doable. And that is what we are going to talk about now. So basically there are 5 steps. One is, first we decide at this point in time what is the essential package that we are going to ensure that the people will be benefiting from. And then what is the proportion of population that gets this benefit? What is the out-of-pocket payment by this population for accessing that benefit? And then introducing quality dimension and the equity dimension. I'll take you through this step by step. Let me warn you, this may be very simplistic, but the audience is not researchers or academicians. The audience for this sort of calculation is the policymaker, because ultimately they are the ones who have to say, yes, this is the path we want to go to. We want to go from 40% to 50%. Okay? So, identifying the packages. We can talk of primary healthcare packages like outpatient care, immunization, antenatal, etc., etc., and secondary healthcare like inpatient, specialized services. There was a recent presentation at the ministry level where they talked of the various programs, TB control program, what is the coverage, malaria control program, what is the coverage. A lot depends on each state, what they want to say, decide, say, for my citizens, I will assure this essential package. I'm just taking for this example, outpatient services, inpatient services for secondary care, and maternal health care. Just as an example to take you through the next few slides. Now, calculate the proportion of people using these services currently. So, what is your outpatient contact rate? What is your full immunization rate? Full antenatal coverage rate, or what is your admission rate? Now, these are all data which is available easily, be it the NSSO data or the coverage evaluation reports, or if you are working in the EAG states nowadays, now they have these annual health surveys. All this data is available very easily and can be taken from there. And then I'm again using the example. If you look at it, curative care, the green bar is people, outpatients or inpatients who received the care, and the red bar is people who did not receive care. Now, where did I get these figures from? This is from NSSO 60th round. If you analyze that data from just the report, you don't have to go into the this thing, it says that about 18% of the people who needed outpatient care could not get it because of various reasons. Similarly, if you look at maternal health services, about 30% of women who were pregnant did not get full antenatal checkup, or could not deliver in an institution because of various reasons. Okay, so now straight away you know what is your population that is covered against those basic services. Now, next step, which is we are talking of financial coverage. For accessing, those who have accessed the services, do they get it free of charge, or do they have to pay out of pocket? And here we look at, again using NSSO data, we find that only about 25% received it free of care when they went for outpatient. So we are talking about 70% received outpatient care, but out of that 70%, only 25% got care free when they went to access that service at the point of care. Rest 75% had to pay some money out of pocket. It may be for medicines, as Geeta was saying, which is the most common expenditure, or it could be for consultation fees, or it could be for informal fees, whatever, but they had to pay out of pocket. And when it comes to inpatient services, the situation is even worse. It's just some 12% who get free care. Rest all have to pay out of pocket. Then we can introduce a quality dimension. For example, we can look at dropout rate in DPT-3, or whatever average delay between symptoms and diagnosis. These again are very simple, and data is available, exists currently. And the equity dimension, okay, what happens, the same coverage in terms of population, in terms of services, in terms of financial out-of-pocket payment for the poorer sections and for the richer sections. Again, a lot of this data is available, easily available, and can be captured. Now, I try to put all this together into one single diagram, and if we look at say outpatient utilization and inpatient utilization, which is what we are talking of, population coverage. That is, people should be able to go to a clinic or primary health center and get outpatient care, or when they need admission, they should go to a hospital and get admitted. And we find that while outpatient services, there's good access, inpatient not so well, good access. When you look at the ANC coverages, okay, maternal health, very good, but we really, in India, we really fall low in terms of out-of-pocket expenditure. Again, it's not rocket science, it's been talked about, 70%, 72% of our health expenditures by private out-of-pocket expenditure. But what this graph shows us is, in one graph, what are the three dimensions, what are our performance in terms of these three dimensions, and then policy maker can decide, okay, what should I do? Maybe instead of spending more money on outpatient utilization, I should spend more money to reduce the out-of-pocket payment. That's where my focus should be. So this is I did it like the thing for the India level. Each state, you can do it and take it to your policy maker and say, listen, Jharkhand, this is the state, or this is the level, or Chhattisgarh, this is the level, and we need to move. If we want to achieve universal health coverage, we need to move along this path. There are some limitations, of course, to this. One major limitation is how do you define this essential package? Because, I think Professor Bruno talked in the morning how we had comprehensive primary health care, and then people said that is too comprehensive and too wide, and so made it selective primary health care. And so like that, I've sat in on various meetings, and my colleagues who are policy makers will also agree. There's never an agreement, consensus on what is an essential package. Should it include outpatient, inpatient? Should it include maternal health? What about malaria? What about leptospirosis control? What about dengue control? So always there is people who want to add on to this essential package, and then it becomes bigger and bigger and unmanageable. What are the agreement on indicators? Most of these is not too difficult. Availability of disaggregated data, it is becoming much more easy now compared to a few years ago. And yeah, we need to validate. This is just a first presentation to this audience. You all need to take it back to your states and try it out and see whether it works or not. It's a work in progress. Like I said, I may be accused of being very, very simplistic, but like I said also, that my audience is a policymaker who has to attend various meetings, answer many people, and then at that point in time, he doesn't want to listen to various theoretical exercises. He wants simple solutions, and that's what I hope to give. Thank you very much.
Thank you, Dr. Devdasan.